NRP stands for Neonatal Resuscitation Program, and it really has become our gold standard of how to resuscitate babies in the delivery room. And we extrapolate a lot of those concepts for codes in the NICU too. What we're covering today is just a few key points from the program. What we highly recommend is that you read and study the book, you take the course, and you become NRP certified. It's super important to become proficient at these steps if you're taking care of babies. And just like everything else in medicine, the more you study and the more deliveries you attend, the more proficient that you'll be. A lot of it is just experience. But there are a few things that you do just have to know off by heart. For example, when you start chest compressions, when the heart rate is less than 60. So there are a few mnemonics that are from NRP or that I've just made up that I'll try to kind of bring up through this video. Hopefully that will help you learn the stuff that you have to just know off by heart. Hi, I'm Dr. Tala, and I've been a neonatologist for 16 years now, so I've been through a few of the iterations of NRP, but today we're going to be covering the most recent one, which is the 8th edition. And there are two big points that we're going to be covering today. The first one is the setup before the delivery. What are the 4 questions that you need to know from the L&D team? And then just kind of setting up the equipment and which team you need. And the second part will go over actually being there at the delivery. So what to do after the baby is born, and we'll pretty much just go through the initial stages, at least, of the NRP algorithm. 1, let's get straight into it. What things should you be considering before the delivery? Well, the first thing that you have to realize about babies is that the vast majority of them do absolutely fine transitioning from intrauterine to extrauterine life. And if they're not fine, it's because they need help with their breathing. Remember, this is very different from adults who are coding. In adults, most of the time, the issue is with their heart. So the emphasis in adult codes is a lot more on keeping their heart pumping or getting their heart restarted. In babies, nearly all the time, just giving the babies the breathing support that they need will be enough to resuscitate that baby. So in your minds, as you're going towards the delivery, what you should really be thinking about is what sort of respiratory support is this baby most likely going to need. That's going to be the key part of all of NRP. To know how many team members you should have at the delivery and kind of which equipment you should definitely have ready, there are 4 key questions per the NRP that you should be asking of the obstetrical team or just asking the L&D team. The first one is, what is the gestational age of the baby? Obviously, we're going to be treating a term baby very differently from a 22-weeker, for example. The second question is about the amniotic fluid. What is the amniotic fluid like? Is it clear? Is there meconium? Is it bloody? Obviously, all these things could change our management as well. Number 3, are there any additional risk factors? This encompasses just about everything. Are they twins? Does the mother have PIH, IDM? What did the strip look like before the baby was born? So really all the kind of background data about how worried we should be about the status of this baby. And 4, what is the umbilical cord management? So really here is the time that we make the decision, are we going to do delayed cord clamping and for how long? The mnemonic I came up for this was RAGU, R-A-G-U, just like the pasta sauce. They're in the wrong order, but that doesn't really matter. So R is for risk factors, A is for amniotic fluid, G is for gestational age, and U is umbilical cord management. RAGU, now you can remember it. Who actually goes to the delivery is basically going to depend on those 4 questions, as well as just generally how worried you are about the baby. But there should always be somebody at a delivery that at least can perform the initial steps of NRP. And now that you know what sort of situation you're in, you should really perform a pre-resuscitation team briefing. In the latest edition of NRP, the 8th edition, the concept of teamwork and communication between the team members was really emphasized. It has been shown numerous times that if the team isn't working together as a unit, then that is making sure that everybody is on the same page and everybody knows their roles for the resuscitation. We should identify the leader and then assign everybody the roles. Who's going to be putting on the pulse ox? Who may end up having to record information down? You should know where the equipment is and assign somebody to get the equipment if it's needed. There should be somebody assigned to call for additional help if that is needed too. Always stay calm, at least on the surface, stay calm and use clear professional language. These are all the things that are going to make us work so much better as a team. Then before delivery, obviously you have to make sure that the equipment is ready. I'm not going to go over the details of every single piece of equipment that you should need, but just realize that one, you should have a checklist where you make sure that all the equipment that you actually might need is around you. And two, that equipment needs to be very close to you. You don't want like the umbilical vein catheter kit in the NICU. Everything needs to be within close vicinity to the delivery. But obviously, depending on how risky the birth is, you don't actually have to get it all out. You don't have to rip the code card every single delivery that you're going to. The one thing you will definitely need for every single delivery is a way to provide warmth. So basically, hopefully, a preheated warmer, some warm blankets, and a hat. If the baby is going to be less than 32 weeks, then you're probably going to need some additional heat. So often we'll use like the plastic wrap as well as a trans warmer. I often tell people this that don't necessarily work in the NICU. If a baby is born really anywhere, the most important thing that you can do for that baby is make sure that the baby stays warm. Then you need a way to clear the baby's airway, whether with a bulb suction or with an actual suction catheter. Obviously, you're also going to need a way to provide oxygen and positive pressure ventilation for the babies. When you're setting up oxygen for a term baby, then you can set the blender at 21%. For a baby that's less than 35 weeks, you can set the blender between 21 and 30%. And we'll talk a little bit more about this in a second. A pulse oximeter should also be available so you can check the baby's SATs. And then EKG leads, the laryngoscope, the ET tube, the umbilical venous catheter tray, as well as medications should all be available even if they're not actually opened and sitting in the bed. Just realize that you have to know exactly where it is and you have to have access to it very quickly just in case you do end up needing it. Number two, let's get into the actual delivery and the NRP algorithm. So let's say that the baby is delivered and they did delayed cord clamping on whatever was decided upon between the neonatal and the labor and delivery team. What do we do next? Can the baby stay with the mother or do we immediately have to bring the baby over to the radiant warmer? The answer is that the baby can stay on the mother's chest if you can answer yes to the following three questions. The first one is the baby term? So does the baby look like it's at above 37 weeks gestational age? And this baby does look pretty term. The second question is does the baby have good tone? So that kind of muscle strength, is the baby kind of kicking and moving around, not like lying like a rag doll like this baby. And the third question is the baby breathing or crying? So is there like good chest movement? Can you hear some noise from the baby's mouth? If you can answer yes to every single one of those questions, then the baby can stay with the mother on the mother's chest. So the little mnemonic I came up with for you is it is better, B-E-T-T-E-R, for the baby to stay on mother's chest. So all of those three capital letters have to be satisfied. So B, breathing, T, term, above 37 weeks, and T, tone, or good muscle strength and everything. So it is better for the baby to stay on mother's chest. I mean, you're welcome. Just a reminder, if the baby is staying on the mother's chest, you don't just put the baby there and forget about it. We do need continued evaluation, at least the 5-minute APGAR, and then making sure afterwards that the baby does stay warm and is continuing to breathe and is pinking up. So make sure that that baby is continuing to be evaluated. If the answer is no to any one of those three questions, then the baby automatically has to come over to the radiant warmer. So either the baby is less than 37 weeks, or the baby is not crying or breathing, or the baby is just like limp, like a rag doll. For any of those reasons, then the L&D team needs to hand off the baby to the neonatal team on the radiant warmer. Now let's go down the NRP pathway. If the baby is on the warmer, then the first 5 initial steps are always warm, dry, stimulate, position airway, and then suction if needed. A quick aside here, I asked ChatGPT to come up with a cute mnemonic so you can remember the order of these steps, and it came up with this: wiggly dolphins swim past sharks, which I really kind of liked. Let's spend a second on each of these. So warmth, provide warmth under the radiant warmer. The baby should stay uncovered. We should keep the baby's temp between 36.5 and 37.5, although obviously initially you're not necessarily checking the temperature. Generally, put a hat on the baby because as you all know, babies can lose a lot of heat through their heads. Then dry. We want to make sure that we don't lose any heat loss through evaporation. So using a warm towel or a blanket, gently dry off the fluid. If the baby is premature, we generally use other equipment like plastic wraps and trans warmers. S is for stimulate. Often just drying the baby is enough stimulation, but sometimes a baby needs more than this, just to kind of be woken up a bit. So you can gently stimulate the baby's back, so just kind of like by gently rubbing the baby's back like that, or the baby's trunk, or sometimes I'll just kind of like rub or just kind of flick the baby's feet like that. Do not shake the baby and don't over vigorously stimulate the baby. Obviously, that is not good for the baby at all. We've all definitely seen that happen though. Then position the baby. Position the head and the neck. We want the baby in a sniffing position so that the baby's airway is open. Don't flex the neck and don't hyperextend the neck. The baby should be in a perfect sniffing position, or basically where the eyes are looking up at the ceiling. And then clear secretions or secretions. This is only if it's needed. Don't suction a baby out if you feel there aren't any issues. So you can gently suction with a bulb syringe, and you all know how these work. When you squeeze it in, it will kind of create that suction, and then when you let go, it will suction up all the secretions. So generally what you want to do is turn the baby on one side when suctioning so that all the secretions pool in the cheek and you're less likely to irritate the vocal cords and the back of the mouth. So turn the baby to one side, allow the secretions to pool, and then suction out the cheek like that. And then if you also see secretions in the nose, then you can also suction out the nares. Always suction out the mouth before the nares. And you can remember that because it's an alphabetical order. M and then N. After the initial warming and drying, you need to reevaluate the baby and determine the next steps according to the algorithm. Does the baby now look good? Is there good tone? Is the baby breathing? Is the baby pinking up? If so, then you don't have to do any more active resuscitation and you can just continue to monitor the baby. But let's say though that the baby at this point is now breathing, but maybe there's some respiratory distress. So maybe the baby's grunting or having really bad retractions, or the baby is breathing but still looks really blue. So obviously at this point, we need some more respiratory support. So somebody should be putting on a pulse ox probe. So generally we'll put that on the right hand so that it's a pre-ductal reading. And then we need to give the baby some form of respiratory support. So if the baby just looks a little blue, then we probably want to give just a little bit of free flow oxygen. Usually we give this in the same way that we would be giving the positive pressure ventilation or CPAP, but we don't want a tight seal. Instead, we'll just bring the mask really close to the baby's nose and mouth and allow some oxygen to kind of get to the baby's face. So obviously at this point, if your FiO2 is still set at 21%, then it needs to go higher than that. So generally when we first start giving free flow oxygen, we're doing it at about 30%. So you can just kind of position the baby's mask like that. The further that the mask is away from the baby's face, the less FiO2 or additional FiO2 the baby is receiving. Hopefully at this point you've put on the pulse ox probe and you can titrate the FiO2 to make sure that the baby's SATs are staying within the NRP guidelines. If a baby actually has respiratory distress, so it's grunting as well as still looks really blue. So for example, let's say it's a 34-week infant, for example, and you don't just want to give the free flow oxygen, then in this case, you'd probably want to help the baby with actual CPAP. So you would put the mask over the nose and mouth of the baby and actually provide a tight seal so that you are giving CPAP. Here, I'm at home, so I don't have the flow to provide the pressure, but generally you want to give a PEEP, the CPAP pressure of 5 centimeters of water. Then whether the baby ends up staying with the mother or needs to come to the NICU will depend on the status of the baby over the next few minutes. Obviously, it will also depend on their gestational age and whether you can actually get them off oxygen and they seem to be breathing easily in pink and having good tone or not. Let's go back to the algorithm though and take a slightly different path. Let's assume at 1 minute though that the baby isn't breathing well or has any of the following. So A is not breathing, so the baby's apneic. B, the baby is gasping, which is basically ineffective breathing. So every now and again, the baby's just going like that. Or C, the heart rate is less than 100 beats per minute. And without leads, the most effective way of figuring out the heart rate is by listening with a stethoscope to the left side of the chest. So hopefully you've already determined somebody on the team that's going to listen to the heart rate with the stethoscope. You can listen for 6 seconds and then multiply by 10. Generally, whoever's actually listening, it's helpful to actually tap out the heart rate as well. So for example, if you hear 8 beats in 6 seconds, then the heart rate is 8 times 10 or 80. So let's say either the baby's not breathing, gasping, or the heart rate is less than 100, then at this point, at 1 minute of life, then you need to start positive pressure ventilation. And if the pulse ox isn't already on, then somebody needs to be putting on the pulse ox on the baby. Let's talk about PPV now, or positive pressure ventilation. Generally, we use a flow inflating bag like this one, where you're squeezing the bag to get the PIP. Or we use a Neopuff, the T-piece resuscitator, where you're basically putting your finger over the hole to create the PIP. You could also use a self-inflating bag. Whatever you're using, hopefully you already have this set up with a PIP or a peak inspiratory pressure of 20 to 25. So that's when you're pushing the air in. And PEEP, the positive end expiratory pressure, or the CPAP you're giving, of 5. Again, for a baby more than 35 weeks, we use 21% initially. And for a baby less than 35 weeks, we use between 21 to 30%. On the little ones, generally less than 30 weeks, I usually start at 30%. Then you're giving PPV at 40 to 60 times a minute. So when we say 40 to 60 times a minute, we mean that every time we squeeze the bag to give the PIP, then that counts as 1. So you're squeezing the bag 40 to 60 times a minute, which is at the rate of saying breathe 2, 3, breathe 2, 3. So you see I'm saying breathe instead of 1, 2, 3. It sounds super easy, but in a code, it's easy to lose our minds. So get used to saying this out loud each time. Breathe 2, 3, breathe 2, 3, breathe 2, 3. The best sign that PPV is working is that your heart rate is going up. If the heart rate is not going up by 15 seconds, then you need to start the ventilation corrective steps, or, I know that you all know this mnemonic, it's Mr. SOPA. Remember, you're supposed to go through these in order and then evaluate the baby after every 2 steps to see if there is an improvement in heart rate as well as in chest rise. Right, so what does Mr. SOPA stand for? Let's go through them one by one. M is for mask adjustment. So the mask should be covering the mouth and the nose, and it should be a good seal. I generally hold the mask with one hand, the C-shaped hold like this. But if someone else can bag, you can hold the mask with 2 hands like this. Just make sure that you're not resting the rest of your fingers on the baby's eyes or the neck or anywhere else. So when you're readjusting the mask, just make sure there is no leak anywhere. Often the leak is right between the nose and the mouth. So you really kind of have to press that down. Sometimes there isn't enough air in this portion of the mask and you actually have to inject more air into it or just grab another mask. And then sometimes going to the 2-hand hold is better just because you get less of a leak. You'll know you got a good seal if the pressures that you're getting with the PIP and the PEEP are good. R is for reposition of the head and neck. Again, we want the baby in a sniffing position, so not too flexed and not too hyperextended. So midline and in a sniffing position. S is suction the nose and the mouth. Maybe the airway is blocked by secretion, so it may help just bulb suctioning, like we said, turn to the side, or sometimes you may have to suction more deeply and end up going down with a catheter. Again, as a reminder, you do the mouth before you do the nose. O is for open the baby's mouth. Here the baby's mouth is really nice and open. This always sounds a bit odd, but often the baby's mouth is only slightly open, and opening it more fully can decrease the resistance to pressure. So just like the previous two steps, after you do the S and the O, reevaluate the baby. And if you're still not seeing any improvement, then again, proceed to the next step. P is to increase the PIP on the PPV. Generally, you go up by about 5 centimeters of water every time you're going up. But you shouldn't be going above 35 in a preemie and 40 in a full-term baby though. Sometimes it's this change in pressure that finally gets the babies to open up. And A is for alternate airway. If you've reached this far and you really haven't seen any improvement in chest rise or in the heart rate, then you need to proceed with an alternative airway. So either you have to intubate the baby with an endotracheal tube or you have to insert a laryngeal mask. If, however, at any stage you see that the chest has started to move, then announce this to the team. The chest is moving now. Hopefully, one of these corrective steps, even before the intubation, will bring up the baby's heart rate and move the chest. If the heart rate, for example, is now above 100 and the baby starts to take breaths, then you can slow down your rate of PPV until you eventually stop it. So even if the baby starts breathing, don't go from giving PPV at like 60 times a minute to suddenly stopping. Just slowly slow it down. During this time, you hope that the baby has an oxygen probe on their hand and you're titrating the baby's FiO2 for their appropriate SATs. Remember, babies aren't supposed to be pink until they're over 10 minutes old. So if everything is improving, then just be patient. If you have intubated the baby and the baby's heart rate is still less than 60, then at that point you need to start chest compressions. If you are anywhere close to starting chest compressions, then make sure that you crank up the FiO2 to 100%. We'll talk about chest compressions in a separate video, but that FiO2 to 100% is really key. So many times we end up rushing to the delivery room and somebody's resuscitating a baby and the baby is still on the 21% that they'd originally started on. For now, let's assume your PPV steps helped the baby and the baby started crying. What do we do next? We do what NRP calls post-resuscitation care and team briefing. Really, at that point, you need to evaluate whether the baby can stay with the mother or needs to come to the NICU for further evaluation and management. And that will really depend on how quickly the baby turns around and whether they need any extra oxygen and just their overall tone and work of breathing and their activity. Well, those were the initial steps of NRP. Remember that obviously if you're reaching chest compressions or intubation, then you should definitely be calling for help. But if at any point before that you're concerned that the baby isn't turning around fast enough, then call for help. There's always somebody in the hospital that can help you, I hope. And this is your homework assignment. So 1, what are the 4 questions you should ask mother before delivery? 2, when is a baby allowed to stay with a mother? 3, what are the initial steps of resuscitation? 4, under what situations do you start PPV? And 5, what does Mr. SOPA stand for? I really hope that you learned something today. If you got this far, then please like this video, subscribe to our newsletter if you want the PDF summary of this, and become a channel member if you want a lot more behind the scenes views and other stuff that we're offering.